Hello, Matthew. I am thrilled to introduce our next speaker, Professor Matthew Large. Matthew works in the School of Psychiatry at the University of New South Wales, and he's a leading expert on issues related to risk assessment in mental health, in suicide prevention, and me and my colleagues, we were lucky to hear Matthew's lecture last year at the World Congress on Suicide Prevention in Piran, Slovenia, and we were really impressed by that presentation. It was very thought-provoking. So I am really happy that Matthew accepted our invitation to share his thoughts about suicide risk assessment. So, Matthew, when you are ready, we are more than eager to hear what you want to say.
So thank you so much for inviting me today. I was asked to talk on this topic, a reevaluation of the high risk approach to suicide prevention. And I'm from Sydney, Australia, and that's a photo of our local and famous beach, Bondi Beach. I'm a psychiatrist in full-time clinical practice. I'm not a professional academic. I'm a professional psychiatrist. I work in public hospitals. I've spent about half my time working in emergency departments and other times at inpatient wards, and I've done some other bits and pieces. And I've had a long-standing interest in suicide, um, probably for all the sorts of reasons that lots of people in the audience have an interest in suicide. I just want to acknowledge mostly the co-authors of the research that I've done, and I don't really have any meaningful, conflicts of interest. I'm employed by the state health department, and today I want to cover 5 areas. So it's a content-rich talk. Um, Firstly, I want to talk about what the high-risk approach to suicide prevention is. And then I want to do a little overview of the maths of risk assessment, which um, is a bit abstracted, but actually is very important. And then I want to just overview some crucial papers saying what the science actually tells us about risk assessment. Then I'm going to make an interpretation of that in terms of what that might mean clinically. And then I'm going to make some suggestions as to what we as a profession and a community need to do um, in response to really the weakness of suicide risk assessment. So this is a World Health Organization pamphlet. It's extremely well known. It's actually a little bit old now. It's 2014, but it hasn't been replaced, and it's still present on the WHO website. And it's certainly not the only document espousing the high risk approach to suicide, but it's a prominent one. And very early on, it has this panel on the right here that says the purpose of the document is to explain risk and protective factors and related interventions. And the article or the pamphlet conceptualizes 3 sorts of interventions, which are described respectively as universal, selective, and indicated. Universal are interventions designed to reach an entire population. So, for example, you might want to do something to limit republication of suicide stories at a national level. And that would be a universal intervention, and no risk assessment is required. And then there are selective interventions, which are prevention strategies that target vulnerable groups of people. And that really doesn't require a risk assessment, but it may identify individuals with risk factors. So, for example, Stephen Stack is going to talk about the importance of financial stress in suicide later in the day. And so you could, for example, identify a group of people who were poor and give them more money. And that would be an example of a selective intervention, but there are lots and lots of those. And what I'm particularly concerned about are so-called targeted individuals, which target specific vulnerable individuals. And these interventions are driven by, and these three terms are synonymous: suicide risk assessment, risk categorization, and suicide prediction modeling. So, of course, the term universal actually really means national. I'm down here at the moment, you're up here somewhere. And of course, there are very important differences in national suicide rates, in the composition of suicides, and certainly at a national level, there are lots of things that could and should be done in lots of countries, but they're not really universal. My father was a radio astronomer, and the reason we moved from the United Kingdom to Australia was that the bottom half of the planet points into the middle of the Milky Way. And of course, there are no truly universal suicide prevention strategies. And I wonder why they chose that term in the first place. But moving on, universal strategies or national strategies are pretty tricky. So here is a graph of 17 important national interventions that have occurred in Australia with the aim of reducing suicide. And the author of the paper that this I lifted from believes that none of them were effective. I don't quite agree with him, but it is quite a tricky thing to do to bring about changes in national suicide rates. There are important differences between countries, but it's quite tricky to change the suicide rate within your own country. But that's not really part of the high risk approach, as I've said. I'd like to make a plug for two groups of people who have a very high suicide rate. And this is from two of my papers. This first graph, and I'm going to show you a second one, is a plot of the suicide rates reported in studies of psychiatric inpatients between about 1930 and 2010. And on the vertical axis, that's a natural logarithm. And studies, this is natural logarithm of 7, is about 600 per 100,000 per annum. So whole groups of psychiatric inpatients have rates of suicide that are 50 times that of the general community. And I think there are lots of really selective interventions that we should do to prevent suicide among inpatients. And actually, once they're discharged, things get a bit worse. This is a graph, it's an amalgam of two of my papers, one in JAMA Psychiatry and the other in the British Medical Journal Open. And it shows the suicide rate in the weeks after discharge from psychiatric hospital. And in the first week, suicide rates are enormously high for discharged patients in the, according to the global literature, and up to 300 times that of the general community. And you can find papers where they're 500 times higher. So these are two groups that I think where there's a single risk factor, that is, they're either an inpatient or a recently discharged patient, where all sorts of things might be warranted to help them. But indicated interventions are a bit different. In theory, the high risk approach should guide treatment for individuals with a higher probability of suicide. And to do this, you have to decide who is at high risk. And here I'm about to move on to the next part of the talk, which is to understand the maths or the metrics a little bit. So when you see a patient and make a decision as to whether they may be at higher risk or lower risk, you're dividing the patients into two groups, and it could be more groups, it could be medium risk as well, but all the research is about higher and lower risk. And then over a certain period of time, there will be an outcome. And the bottom two, these are all tragedies, everything that occurs in this tragedy, and all of these people are survivors. And but it creates a contingency table of 4 different outcomes, and they can be used to generate a number of metrics, and I'm going to concentrate on 3 of them. The first is sensitivity. So the sensitivity of a high-risk categorization or a suicide risk assessment is the proportion of all the suicides that get captured in that high-risk group. It's defined entirely in that bottom line, and with no reference at all to the number of people who don't suicide. So that's the sensitivity. And then there's the odds ratio, which is the increased likelihood that a person classified at high risk will suicide compared to a person classified at low risk. And any number greater than 1 implies that there are more suicides in the high risk group. And interestingly, those first two measures are insensitive to the number of suicides and the number of survivors. In the first case, because all of the data is derived from the bottom line. In this case, derived because all the terms are in the bottom and the top line. But an odds ratio of 1 suggests a higher proportion of suicides in the high risk group. And of course, there are many other measures. And I decided to take a discussion of those out of this because I think it's maybe a little bit technical, and I won't be using those measures in the rest of the talk. And then, of course, there's the positive predictive value, and that is the proportion of all people classified at high risk who do go on to suicide. And that's very sensitive to the base rate because the terms are unevenly spread between the survivor and suicide line. So PPV, positive predictive value, is the probability that a high risk case will suicide. And it's really the inverse of that that's important. So 1 on PPV, which is the number needed to predict. So that's the number of people you need to classify at high risk of suicide to predict 1 suicide. And that is very sensitive to base rate, as illustrated in this next graph. So this is from a paper of mine about involuntary mental health law and involuntary treatment. And it shows that even with a hypothetically excellent risk assessment tool, with events that have a low probability, so this is roughly where suicide is, you have to classify lots and lots of people as at high risk in order to capture 1 single person who will go on to die by suicide. And I'll talk about PPV a little bit more. So what does the science tell us about sensitivity, PPV, and odds ratios? And here I'm going to describe 4 papers. And they're all meta-analyses. 2 of them are conducted by my research group and 2 of them by 2 other research groups in the United States. And between them, they cover 50 years of research into suicide risk factors and suicide risk categorization. And here's just a little summary of the papers. So Franklin looked at any population they could find. They looked at prospective cohort studies and they looked at all risk factors, but didn't really do any examination of risk models. In my 2016 paper, I looked just at patients. I was really only interested in risk categorization, but I only looked at prospective cohorts. But I looked at 2 sorts of studies. One, studies where there was retrospective modeling, they're exploratory studies, and study where there was prospective decisions about what a high-risk group was, so validation studies. And then the next 2 studies are totally complementary. So they're both studies that examine risk modeling. One of them only examined a very narrow risk of validated cohort studies, and the Cork study examined all the other studies, the cohort and control studies, using exploratory markers. And I'm just going to run through the results of these 4 studies, noting that there has been like a kind of explosion of research in the last 20 years into suicide risk factors. And this is from Franklin et al., and only looking at prospective cohort studies, longitudinal cohort studies. And there are thousands of papers per year reporting thousands of different effect sizes or risk factors. So there's really a pair of studies by Franklin and Ribeiro published in 2016 and 17. And it was a meta-analysis of risk factors for suicidal ideas, suicide behavior, and suicide. But I'm going to concentrate on just the results of suicide. They didn't specify what population they looked at. And, you have to, if you read the papers, you have to be in some awe of the size and sophistication of their research effort. And here are their results of their top 5 risk factors for suicide, which were, as you can see on the slide, psychiatric hospitalisation, prior suicide attempt, prior suicidal ideation, lower socioeconomic status, and stressful life events. And in the 4th column along there that says OR, or odds ratio, you can see that the odds ratios that they found are comparatively modest. In Australia, male gender is associated with an odds of suicide of 3.5. And in their study, that had the same effect size. One thing that very much surprised me about this study is that suicide attempt was no more lethal, if you like, than suicidal ideation. And I'm not going to talk about it, but I conducted a whole other study looking at a much broader data set and found exactly the same thing, which surprised me greatly. And then socioeconomic status and stressful life events. And of course, there are a whole lot of other risk factors that were more modestly associated with suicide. And Franklin and Ribeiro, they concluded, and this is actually just a direct lift from the abstract, and I'll just read it out. The present random effects meta-analysis produced several unexpected findings across odds ratios, hazard ratios, and diagnostic accuracy analysis. Prediction was only slightly better than chance for all outcomes. No broad category or subcategory accurately predicted far above chance levels. And they also commented that predictive ability has not improved in 50 years. So it's a very dramatic thing to say. And then I'm moving on to my study. We defined a risk category as one that was based on more than one risk factor. And we only looked at psychiatric patients, and we found 53 longitudinal cohort studies. And as mentioned earlier, we examined retrospective data modelling and prospective data modelling. And we looked at a few other characteristics of the studies, including year of publication. Overall, we found that high-risk patients had an odds of suicide of 4.84, which was only a little bit bigger than gender in the general community. And it had a sensitivity of 56, meaning that almost half of the patients who suicided later were not classified as high risk. The study had a positive predictive value of 5% over just over 5 years of follow-up, indicating that high-risk patients, legitimately categorized high-risk patients, have a suicide rate of about 1% per year. Very surprisingly, we found that exploratory models and validation models produced the same result. We also found that risk categorization hasn't got any better in 40 years of research. And what really surprised me was that more complicated models that incorporated more risk factors don't behave any better than more simple risk factors. So that really surprised me. I had a quite different hypothesis. Now, this paper was published in 2016 and was closely followed by 2 other somewhat similar papers. And it got editorialized in Scientific American in early 2017 with the heading "Suicide Risk Assessment Doesn't Work," which it's not exactly what I said, but that's how my results were interpreted, and caused quite a lot of publicity and some controversy, I have to say. There've been a lot of other studies published since then, and I'm really only going to focus on 2 of them. So the third study I'm going to talk about is also my research group, where we looked at any suicide prediction model that we could find that was exploratory. So we didn't examine the validated models. We just managed studies where they tried to fit the data to a high-risk model. And we looked at every sort of way that data points can be assembled, all the way from clinical judgment to machine learning. And this study found a slightly higher odds ratio, that high-risk patients were nearly 8 times more likely to suicide than low-risk patients, but the sensitivity was quite poor, and that the majority of suicides occurred in the low-risk group. The positive predictive value was low as well. 2.8% over 5 years of high-risk patients went on to suicide, and that meant that among high-risk patients, the number needed to predict over like clinically meaningful timeframes was in the thousands. It was about 2,000. And so that meant that, using a risk assessment to classify a group of people in order to capture one person who will then go on to suicide, you actually have to classify 2,000 other people as being at high risk. And there were some other interesting findings in this. So this is the graph from the paper, and the vertical axis is the odds ratio. So that's essentially the number of times more likely that a suicide will occur in the high risk versus low risk group. And on the x-axis, we have suicide prediction models of increasing complexity, starting with clinical judgment. And there were a bunch of papers about clinical judgment, and there are a bunch of papers that use 2 or 3 factors to define a high risk group, 4 or 5, 6 or 7, 8 to 12, 13 or more. And then there were a bunch of machine learning studies. I think there were about 13 machine learning studies. And the really interesting thing to my mind was that clinical judgment was not convincingly better or worse than machine learning or any other method, and that suicide prediction models with more information in them didn't produce a better predictive result. And I have to say that surprised me. And that surprised me in a situation where the models had every chance to work. This is retrospective modeling of previously collected data. Surely more complicated models should have worked better, but actually they quite convincingly did not. The flip side of the Cork study is a study by Belcher, and he looked at longitudinal prediction models, and instead of looking at exploratory models, he only looked at validated suicide prediction models. His population, or their population, was they looked at adults over 18, and instead of using meta-analysis, they used the studies to assemble a simulation. And this is their simulation. So here, every little blue dot is a survivor, and every black square is a person who has died. And you can see by moving the vertical lines along that you can achieve more sensitivity by moving this line backwards. So if you moved it back all the way here, you'd have 100% sensitivity. But you do that at the cost of incorporating lots and lots of other non-suicidal people or non-suiciding people in your high-risk group. And he or they reached the conclusion that there was no place that you could put this line where it was going to be clinically meaningful. And so they've said about their study, global classification accuracy was good. Now, what that means is that the majority of people were classified correctly. That actually doesn't really tell you very much. If I classified everybody who's listening to my talk as at low risk of suicide and then followed them up for 2 years, there's likelihood I'd be 100% correct. So global classification accuracy actually doesn't mean anything, or means very, very little. But the validity associated with a positive result for suicide mortality was extremely low. And they've expressed that as 0.01, which is the same as my study, like around 1%. And the simulations of the results suggest very low positive predictive values across a variety of population assessments and characteristics. And the next thing was really, I think, an amazing statement. Conclusions: to date, suicide prediction models produce accurate overall classification models, but their accuracy of predicting a future event is near zero. So that's in JAMA. It's by an American group. So essentially 3 or 4 international groups have really come to very much the same conclusion. And I'm just going to quote, all of these are from the abstracts of these 4 papers. So categorization based on the presence of multiple risk factors did not greatly exceed the association between individual risk and risk factors. That's my first study. No broad category or subcategory actively predicted far above chance levels. That's Franklin. Suicide projection models that include fewer risk factors perform just as well as those that included more risk factors. That's Cork. And then Belcher again, predicting a future, the prediction of a future suicide event is near zero. So to summarize these studies, which reviewed an enormous amount of research conducted over 50 years, in these 5 lines is individual risk factors are only modestly associated with suicide. There's been no improvement in our ability to detect suicide in 50 years. Suicide prediction models have a limited sensitivity of around 50% and a very low PPV of around 1% per annum. The number needed to predict are very high, and if you're talking about days, you're talking about up to 30,000. If you're talking about months, you're talking about thousands. And what this last study sadly tells us is that knowing more, i.e. having more complicated models, won't really help you know what's going to happen next. So, well, what does this mean? And I think it means this. If you are going to classify people according to suicide risk, you classify things for a reason. I have a sister who likes to barbecue and makes violins, and when she collects wood to make violins, I'm sure she does it very differently to cooking on a barbecue. And so an intervention for high-risk people must be sufficiently effective and not so burdensome in terms of costs and side effects that it will suit the overwhelming majority of high-risk people who will not suicide. And then if you had such an intervention, and you can kind of think of one, for instance, if you had a tablet that you could give that would prevent suicide, if you had such an intervention, how can you rationally deny it to lower risk patients, people, among 50% of the suicides occur? And if there is no such intervention, what is a risk assessment for? And so when you think about whether you want to do a risk assessment, you need to think about your interventions. And I'm just going to go sideways a bit. And so Franklin and Ribeiro, as well as analysing suicide risk factors, produced this extraordinary paper with the first author, Fox. And they looked at 50 years of randomised controlled trials for suicide prevention. And I won't go into their paper too much. It's well worth reading. Again, unbelievably impressive research effort. And they say the overall intervention effects were small across suicidal ideas, thoughts, and behaviour outcomes. Despite a near exponential increase in the number of RCTs across 5 decades, intervention efficacy has not improved. All suicide ideation, thoughts, behaviour interventions produced similarly small effect size, and no intervention appeared significantly and consistently stronger than others. So that also is it's a paper that's sobering and well worth reading. And just to put it in a slightly other form, well, you've got to think about, if you're going to decide that one person's on one floor and one person is on another, you have to think about what you might do for the person, who's higher that you wouldn't do for the person lower. And I actually think that's clinically a very tricky thing to think through. So I've been going rather quickly, and maybe I'll slow up because we're getting into more uncertain territory. But I think the first thing we need to do is be a bit more modest about our abilities. And then I'm going to talk about the various stakeholders or groups that have a stake in suicide risk assessment. And I'm going to spend about 15 minutes doing that, and then we'll have a bit of time to discuss things. So firstly, what should you do as a clinician? And I think the first thing is to be educated, is to read the literature and and learn about it. And what was crucial for me when I first became aware of this literature is that I had to decide, in a sense, whether I was a scientist. And if I was a scientist, I had to believe the literature. And the literature is really compelling. And it is alarming that we don't know what's going to do next. So we need to keep calm somehow. We need to find a way to keep ourselves calm in the presence of ignorance of future events. And, we have to accept some of the complexity and uncertainty that our patients and colleagues, and probably, complexity and uncertainty in ourselves as well. So I hope that's not too vague. But I'm going to give you some concepts. So this is one of my favorites. So John Maynard Keynes said that uncertainty about the future could have two origins. One is it could be aleatory or it could be epistemic. So if you see a 16-year-old smoker, they may or may not develop lung cancer, but there's no information that you can gather that will tell you as to whether they develop lung cancer. But 20 years later, when they have hemoptysis, they still may or may not have lung cancer. But that is a matter of discernible, whether they have lung cancer is a matter of discernible knowledge. And I think what the Cork study and a few other studies now show is that collecting more information won't necessarily help you resolve the question of whether the person is epistemically going to suicide, and that much of the uncertainty about suicide is actually epistemic, is actually aleatory. And this is from Pokorny, 1983, is one of my heroes. He wrote that the conclusion is, after he did this wonderful study looking at 4,800 consecutively discharged veterans, and did the most elaborate sort of tests and collected data and then followed them up. And he concluded that it was inescapable that we do not possess any item of information or any combination of items that permit us to identify to a useful degree the particular person who will commit suicide. And I apologize for the somewhat outdated language. But the concept of prediction may not even apply. Rather, one is required to identify a suicidal crisis that is already here, a task involving a different set of concepts and skills. And here he was really talking about the difference between aleatory and uncertain and epistemic uncertainty. And actually, a very distressed person who's in front of you may have no risk factors. They might be, a married, educated woman with children and no past psychiatric history, but you still may need to admit them to hospital on the grounds that they're in a suicide crisis. That situation is presented to me on a couple of occasions in my career. And my judgment that they were so distressed and so disorganized was not based on a thought that I knew what might happen next, but because they were so distressed and other people around them were so distressed, and there was no other way of managing that. So that's one concept that I think you should think about, aleatory and epistemic uncertainty, and there's a few papers about this. Now here's another one, prospect theory. So humans, it turns out, are really bad about thinking about probability. And what we tend to do is we overestimate the loss and value of rare events at the expense of much more predictable things. So Australia is a great nation of gamblers. But if you've ever bought a lottery ticket, you've made a prospect theory error, because the chance of you winning is actually pretty low, but the chance of you losing money by buying the ticket is very high. And I mean, this matters in inpatient psychiatry in a very obvious way. So the patient might ask for leave from the ward. They will almost certainly get some value from having that leave in terms of their life, and it's very unlikely that they'll suicide. But we often make judgments that people won't be allowed to have leave. But we should be aware that we have this really quite shocking cognitive bias in favour of disastrous thinking. This is, I think, an important one. So if you're not going to do things in psychiatry on the basis of the patient's risk, well, what are you going to do it on? And I think in the rest of medicine, we make decisions about treatment after a discussion with the patient about the risks and benefits of treatment, and we only insist on involuntary treatment if the patient is somehow incapacitous. And to my mind, a person's ability to make decisions is a much better basis for decision making than our very flawed considerations as to what they may do next. And related to that is, concepts of determinism, chance, and human agency. And so I actually, in a way, I think that the aleatory and epistemic model of uncertainty about suicide, it has its limitations, because here we're talking about decision making by people, and the risk of a person making a particular decision it's very different to looking at, say, cracks on an aircraft wing or some sort of financial risk, and involves all sorts of things, including, I suppose, even game theory in you assessing the patient. This is one of my favourites. Now, at some point in prehistory, probably I think about 500,000 years ago, there was a hominid, not a human, probably, who looked up at the sky and was maybe injured, ostracized from their social group, and made a decision to take their life and committed or enacted the first suicide. But it's very unlikely that any of us are related to that person, because, suicide exerts a negative survival value. And we have got I believe we've got very sophisticated internal mechanisms that prevent us from suiciding and help us deal with all sorts of adversity and suffering, right up to the point of, I don't know how many patients have said this to me, things like, well, I wanted to jump off the cliff, but my legs just wouldn't do it. Kaz Soper is the author to read about this. And he says that suicide is unpredictable because it occurs not because of drivers for suicide, but because of failures in our natural, evolved anti-suicide mechanisms, failures that occur more or less on a chance basis. It's a very interesting person to read. I recommend it thoroughly. And we're still talking about things that we need to do individually. I'm just checking my clock here. I think we need to shed some of our belief in ourselves around this, actually, and accept our own vulnerabilities, that we all have a finite chance of suiciding, that our patients have a finite chance of suiciding, and that we, even as experts and treating people, have no crystal ball. But when you're talking with patients, I think there are a whole bunch of things you can do. And this is from a paper that I wrote, published in the BMJ in 2017 with Nav Kapoor and some people, and you can probably read those. But the most important thing is to conduct a respectful, thorough, and sympathetic assessment. Make sure the doctor-patient relationship is right. Try to understand the patient's individual circumstances. We know that their risk factors can't tell us very much about what they're going to do, but their individual circumstances might help us identify them as a suicidal person. Don't stratify the person into higher and lower risk. Don't rely on the expression or non-expression of ideas or plans, because that doesn't tell you much. Don't dismiss a person as being low risk. Communicate with them. Obviously, things about reducing lethal methods is probably sensible. Use involuntary hospitalisation very sparingly. There's no evidence that hospitalisation prevents suicide. Don't let any patient go home empty-handed. Do something for everybody, and be really careful in your documentation. So that's how I think we should approach patients. And then, of course, families. And I found that talking about absolute risk with families is really helpful. Families really like it. You need to have a think about what you say, but you need to stress the limits of prediction, and then use your therapeutic skills to deal with their anxiety if they have any. Mostly I found families to be quite okay with learning about absolute risk. I think a very important thing is to what to say to students. When I started saying this 15 years ago, I wasn't allowed to teach students on this topic, and they, carefully bundled me off to talk about other things I knew less about. But teach the science and try to get it into the education curriculum. I have a more depressing attitude towards colleagues. I actually never try to argue with colleagues. And I'll just show you this. So Bernal was a sort of co-inventor of X-ray crystallography, and I think he might have borrowed this from Schopenhauer, or someone told me he did. But he thought that people dealt with new information by going through 4 stages, which were: it's not true, it's true but it's not important, it's important but it's not original, it's what I've always believed. So they're Bernal's ladder of accepting new information. But Max Planck, who was much nearer you guys, said something different. He said that a new scientific truth does not triumph by convincing its opponents and making them see the light, but rather because its opponents eventually die, grows up with it. So I've just lost my earpod. Grows up that is familiar with it. So I would counsel not to be educating colleagues very much. Now, third-party providers, and what I mean by that are hospitals and insurance companies, all sorts of organisations actually. They currently use a very wide variety of non-evidence-based risk tools. I mean, eventually these tools will need to be abandoned or contextualised. I mean, cardiology services don't admit patients to cardiology wards on the basis of Framingham scores, but organisations require patience. And I've never been a sort of risk idea entrepreneur in my own service. But I noticed recently in South Australia that, and you may not be able to read this, there's a little warning when you click on the electronic medical record to do a risk assessment. It now tells you should be very careful because the risk assessments don't really work. So this is an interim stage before them being abandoned. In my own health service, in fact, in the state of New South Wales, we've abandoned suicide risk assessment as a clinical audit, as a clinical procedure. It's not in any of our electronic systems anymore. The courts are very tricky. I spent a lot of time, talking to courts, and of course hospitals and prisons and other institutions have their own investigations. And there's a whole lot of things that can happen. And it's important to know the science and give clear evidence if you get called, both as a treating doctor or as an expert witness. And getting the courts to understand this is very important in getting clinicians to change their behaviour. Obviously, the broader court is the court of public opinion, and it's difficult to get a story like this into the media, but there are, chances will happen, and so it is important to communicate our limitations, to the general population. And then, what should researchers do? And look, there are lots and lots of things researchers can do, and I would never stop a researcher from doing anything that they felt they wanted to do. I think the great thing about if you're passionate about something, performing research is, there's a phrase in English like falling off a log. At various times in my career, I've had research topics where it would have been much harder not to do the research than to do the research. But I think there are lots of things that could be done. I mean, there's an almost complete absence of involvement of patients in this area, really. What patients think and feel, particularly about health services. I do think there's avenues for real-time monitoring. And I think some way or other, we're going to have to develop more humane and less traumatic systems of managing people, particularly when we manage them involuntarily. So to recap the talk, and I'm getting to my 45 minutes, the high risk approach should have been better thought out in 2014, in my view. It definitely needs to be better thought out in 2024. The math is pretty easy, but you need to think about it. And I mean, I find that statistical knowledge has a short half life. You need to keep familiarizing yourself with it. Suicide risk assessment has a very modest discrimination and has quite terrible results when calibrated for the base rate. So the PPV and number needed to predict are disheartening. It's also a poor basis for decision making, particularly decision making about the treatments that we have that are currently pretty weak. But what we do next is kind of up to us. The future is not writ. And I've just given some hints as to what I think we should do. And then finally, like a bit of a warning, the idea that we probably all have our own natural native risk processes. And the idea that we can see in the future is a beguiling one. And it wouldn't surprise me at all if risk turns up with another term. For instance, in the 1970s, the term was dangerousness to the self and others, but that got converted to risk sometime in the 1980s. And who knows what the next term will be. So with that rather pretty vase, I've finished my talk.
Thank you, Matthew. A lot of material to think about. I really liked that you not only defined the problem, but provided a lot of helpful concepts. So let's go to the questions. I see that we have a lot of questions, maybe related a bit more to the situation of Lithuania. So I encourage participants on the conference to give questions maybe more directly related to the presentation, so that we could discuss them more. But nevertheless, we still have some questions related directly to the presentation. So one of them is this. It must be pretty hard to gather all the data, because some people from studies might not reveal all what happens in their heads, and some might even do this unconsciously. What if a person tries to outsmart the models because he feels superior, that doctor maybe does not know what happens in their head? So the question may be a bit related to the data gathering.
That's a wonderful question. And the core of it, I think, is a question about theory of mind or folk psychology. And certainly, mentally competent patients sometimes will conceal information from you. And probably they would be better off, or everybody would be better off, if there was some sort of rule that everybody would be honest. But and I often say to patients, I say, look, I know you're worried about me putting you in hospital, and you don't want me to do that. But I think both of our interests are better served if you're straightforward with me. I actually wrote a paper called "Closer to the Truth" with a colleague of mine, Bob Brewer from Canada, where we looked at variables where we had self-reported variables and some objective variables. And it is true that risk assessment worked a little bit better when you had true variables. And actually, when you factored in the discrepancy between true and untrue variables, that improved the prediction model better, but didn't make as much difference as you would think. But it is very tricky to get all the information, and to balance it and weigh it is very, very tricky. But what I'm saying is, to the extent that experienced clinicians can do that, it doesn't work terribly well, and more objective methods don't work terribly well. So, and we're not mind readers, and we shouldn't pretend that we are.
Thank
But it's
you.
a great question. It's a wonderful question.
Yeah, I think other question is also very, very, very good. So a person asks, so if hospital asks me as a worker, which suicide risk assessment scale is the best, which scale we should use in the hospital in order to identify those who may die by suicide. What should I tell them? Should I tell them that there is no scale?
Yes. So my friend and colleague Nav Kapoor, lovely fellow, he did a survey of um, suicide risk assessment tools in English trusts, and he found 165 different tools, 56 different tools, and there are a similar number in Australia, and they're locally developed and widely used. But if someone had developed a tool that worked, it would have been adopted by everybody. But no such tool exists. Now, I suppose one question is to what extent should you rely on the expression or non-expression of suicidal ideation? And actually, I don't think that's so terrible because the odds of suicide, at least in one of my studies, a big meta-analysis associated with suicidal ideation was, I think, 3.4 or something like that, which is not very different to an elaborate risk categorization. And so, and the other thing about talking about suicidal ideation, it is an important communication about the person's inner world. But ultimately, none of these things are predictors. They're not predictions. They're not predictive in a sense. Even if they're a little bit statistically associated, the base rate of suicide is so low that you just have to classify an inordinately large number of people. So I think scales don't work. The NICE guidelines now say that you shouldn't use scales. If you see a person with deliberate self-harm, the Australian College of Psychiatrists say the same. And interestingly, in my meta-analysis in the Cork study, among groups of people who already have suicidal ideas and behaviour, suicide risk assessment works really terribly because most of the predictive value of existing suicide prediction models comes from the presence or absence of suicidal thoughts and behaviours. And if the whole cohort has that, nothing much further can be done. But that too it's a question I've been asked lots of times.
I
But I
imagine.
think we have
And
to be honest.
yeah. And another question is related actually to that, to the hospital setting. Um, why is hospitalization a separate risk factor? I feel like it is a sum of other risk factors. Thanks. I loved your talk.
I don't know, but it's deeply troubling to me that whole groups of people who we admit to hospital have such high suicide rates while they're in hospital and immediately after discharge. And I mean, I wrote a paper called um, uh, "Confound." See, I can't remember the exact title of it actually, but selection of people at risk, failure to protect, and the possibility of causation. So, a person who's admitted to a psychiatric hospital is highly likely, and here I'm going to talk about the possibility of causation. Um, we all understand that we collect people who have suicide risk or risk factors and put them in a hospital. We all understand that the hospitals don't actually protect them very well. But the possibility of causation, I think, is definitely there, and I think it's there on theoretical and empirical grounds. The theoretical grounds are that we know that hospitalization separates you from your social role and supports. It's potentially traumatizing. About 1 in 6 people who are admitted to a psychiatric hospital globally are assaulted, and it's stigmatizing. You have the stigma of being a person who's been an inpatient. And we know that in the general community, trauma, stigma, and loss of social role are risk factors. And to me, there's no reason why those same risk factors shouldn't operate in a hospital. There's also some empirical studies that are starting to come out showing that when you control for lots of factors, um, being admitted to hospital actually increases your long-term chance of a further suicide attempt. There's really no evidence. In the Fox study, um, there's a specific commentary that there's actually no evidence for hospitalisation as a treatment for suicidality. But a great question.
Yeah, yeah, it was really striking to see in one of your slides that one of the top risk factors for suicide were psychiatric hospitalization. And yeah, it's you have a lot of thoughts about that. I guess that maybe the last question would be um, here. I think the question got a lot of likes and went up, and now I have to find it.
Okay, so there's a really good Danish study. I can't
Mhm.
pronounce the first name's author, looking at levels of psychiatric care and hospitalisation, and finding that people who've been in a hospital have a sort of hundredfold risk. People have been in an ED, I think, about a 30 times risk. People have just been in psychiatric care as an outpatient, like an 8 times risk. It's a really it's in um, social psychiatry, psychiatric epidemiology. I wrote an editorial about it. That was the first paper, to my mind, that really highlighted this specific risk associated with psychiatric hospitalisation.
Yeah, I hope that we could learn more from your slides and from the various helpful concepts which you mentioned. I have found that question, the last question, I guess. Um,
Okay.
Hearing that suicide risk scales are unreliable is a bit demotivating, because this could mean that our humane judgment of the suicide risk is even worse. My question: could the use of these tools still provide an organizational or procedural benefit, even if their predictive accuracy is low?
That's possible. Um, that is quite possible. I think there's a much bigger danger that the use of the scale will make the assessment perfunctory. That the like a mathematical model of failed mathematical model or failing mathematical model of what a person might do is actually a bit disrespectful to human agency. Um, and I think I'm not at all pessimistic about. I've been operating without using suicide risk assessment in emergency departments and hospitals for the last 20 years. And it allows for a much calmer, like nicer engagement between patients. If they think that you're not going to make an arbitrary sort of black box decision about whether they're going to go into hospital or not, they learn to trust you a whole lot more. Um, I my view is what you say is it's possibly true about it providing substructure. I think there are all sorts of dangers in it being overread and
Mhm.
in preventing a more thorough, more humane assessment. And to my mind, um, overwhelmingly, these sorts of scales actually have a rather negative value on the interaction with the patient. They may provide some, medical legal protection. They're also a bit of a waste of time. I mean, I do a lot of coroner's reports, and you see these patients who've had where one third of their notes has been suicide risk assessments, and the patient's equally deceased. And the time might have been much better spent, trying to figure out, the predicament they were in life.
I cannot say how I appreciate that colleagues from Lithuania, that a lot of our specialists could hear your thoughts. I think it's thinking on another direction, and very important thinking. So a lot of thanks from us. Also, thank you that you took your lecture in the evening. In the Australia, it's around 7 o'clock.
Yeah,
Yeah.
I have to go and cook my wife dinner, so I
Okay.
have to go.
Okay. Have a
So
good.
thank you enormously for having me. It's been a great privilege, and I very much looked forward to doing it. And I haven't felt in the slightest bit disappointed. I'd love to see your faces, perhaps in 2026.
We hope so too. So have a good dinner again. Really appreciate your talk, and till our next meeting.
Thank you very much. Goodbye.
Bye bye.
Bye bye.